with me.
Right? Hey, happy September. We're here already. It's almost Q4. It feels like Q4. Yeah. How is it where you guys temperature wise? I was telling somebody today, it got down to like 46 degrees last night here. It was really nice.
It's 80 degrees here.
80?
It's 81 here too, but this morning was beautiful. It was nice and cool. I took a walk. It was amazing. Fall is here.
Yeah, when it cools down at night, you can open the windows and yeah, that's my favorite. Open it up at night. Well, today we're talking about fun things. Two things we're talking about today on our roundtable. We're talking about the how we use data here at Specialty Care Management. It's a big part of how we build our programs, how we implement our programs, and how we justify our programs. And we're also talking about all things juicy, all things girl, cervical and sexual health. Doesn't that sound like kind of, I don't know, racy?
Sounds fun.
Yeah.
It's important.
I don't know. We did it to the guys earlier. We talked about prostate health.
We did it to the guys.
Yeah. So you never know what you're going to get here at the round table. So, but I don't know. I'm going to throw it out to you gals. First of all, what do you think? Just the word data. What does that make you feel or think about?
Makes me think about numbers.
Numbers. Yeah.
Yeah. Numbers.
Yeah.
Everything is data. I feel like it's data, research, statistics, everything.
Yeah, and it's important, right? So, one of the things that, as nurses, we're fairly adept at doing population health assessments, right? We do them all the time where we'll look at a population. I remember one of my capstone projects was looking at the overall population health in the community where I lived, and then figuring out, what kind of programs would address the needs that we found in my little North Idaho community. It was a really fun project. And that's what we do. And here at Specialty Care Management, how we use data initially is we'll look at, most of our clients are self-funded employers. And when we'll assimilate that data with a specific purpose in mind, and we're mining through claims data to look for, the risk for high dollar, high risk claims, high cost claims like dialysis, cancer, or whatnot. Now, it's easy to identify the claims for dialysis and CKD, right? If you have a diagnosis of CKD or you're on dialysis, it's going to be there in your claims. It's pretty easy to find that. N186 is the code for ESRD. That's easy to look for. It's kind of sexy, I think, that we can come in and we can use data to not just find that risk that's like in your face, but how do you find the risk for things that aren't showing up yet? Right? So like high risk for silent, when you consider 90% of people that have kidney disease don't have a clue that they have it. Right? I mean, how many people do you talk to, Dale, when you call them up and they've never heard anything about their risk for kidney disease, right?
That's the thing, is it's not talked about as much. We're so used to, when it comes to things that we look at as far as risk factors like hypertension, diabetes, things like that. Doctors usually talk about, you don't want to have a stroke, you don't want to have a heart attack. And so people know that, but they don't talk about kidneys as much. And it's just as important and just as prevalent. So, yeah. And people don't know.
Yeah. And right before our call today, we're talking about the kidney failure risk score. One of the metrics that we use, a data point, one of the metrics that we use in quantifying what an individual member's actual statistical likelihood of progressing to dialysis, one of the metrics that we use is the urine albumin, right? And we were talking about that. And we've seen articles like that lately. How many practitioners are checking for protein in the urine?
Not many. Not as many as you would think.
We get labs all day long, and we're teaching our members, make sure that you're peeing in a cup. It's really important. Protein's a big molecule. Shouldn't be able to get through the filtering unit of the kidney. When it does, we know that there's some holes in the kidney filters, right? And so we're teaching them how to ask for that lab because so many practitioners aren't measuring that. And so there's a lot of ways that we use data here. And one of those is to look through the data to find who has a high risk for having silent or undiagnosed kidney disease. Because truly, you can see the dialysis coming when you can see the codes for CKD4. You know it's coming. That's not hard to find. But how do you find the guys that have stage 4 kidney disease, but it's not diagnosed yet? Right?
Yeah.
So walk us through, what does that look like? How do you know that somebody's a high? Nurses, we can smell it. But yeah. Tell us, what is that? What do you
I'm
see?
happy to jump in, but Nancy, I'll let you jump in too.
No pressure,
Uh,
Nancy.
So risks, I mean, risk for CKD, diabetes, hypertension, you know, what else? Dale, I'll shoot it back to you.
Well, you know,
Diabetes
yeah,
and high blood
diabetes-
pressure drive over 70% of those. So
Yeah.
that's huge. Yeah.
Yeah. So we can see diabetes, hypertension, number 1 and number 2, and then you throw other things in like sleep apnea, gout, frequent UTIs. There's a whole handful of things that we can
Smoking
see.
is a big one.
Smoking, yes, yeah.
Yeah, people say, well,
Um,
there is no code for that. Yes, there is. We see that in the claims, right? The nicotine
Yeah.
dependence or
Yeah.
tobaccos. We
Tobacco.
can see that in the claims.
Alcohol.
Alcohol. Yep, absolutely. Anything that's going to damage the inside lining of the blood vessels, the same thing that's going to damage the heart, same thing that's going to tear up the filtering unit of the kidneys. Why? Because they're little tiny. When you look at the filtering unit of the kidney, or the kidneys, right? It's the nephron. And in the nephron, you've got these little structures called glomeruli. And if you look at a strand of hair, right, this is how tiny the blood vessels are that make up the filtering unit of the kidney, right? So when we jack up the pressure and we jack up the viscosity, diabetes makes the heart work harder it's harder to push syrup, right? And so we can see these things in claims. And then from the claims, we're identifying this person has a high risk for having, I'll bet you, or one time I had a group, looking at a group, this member only had a claim for lupus. That was their only comorbid, but their overall cost, their overall spend was like upwards of $80,000 or $90,000, right? So I bet my license that person has CKD. Not showing up in claims, but I'll bet you anything. Well, if you've got lupus, you've got some stage of CKD. Rheumatoid arthritis is another weird one. You see that in there. What is it? Like 1 out of 4 or 5 people with rheumatoid arthritis have some kind of CKD. So we're looking at these claims and we're looking at what is the combination of diagnoses codes that are going to put somebody at a higher likelihood of having kidney disease. And that's how we work with those folks. If diabetes, it's like this. If it hurts when I slam my finger in the car door, how about I not slam my finger in the car door, right? If diabetes and blood pressure are the things that are impacting my kidneys, how can I mitigate those things? How can I how can I improve them? How can I better control them? How can I put them in remission, right? So that it's not going to tear up my kidneys. Isn't that cool?
Yeah.
The cool thing is that with diabetes and hypertension, these are things that people can control. So
absolutely. Yep.
In most cases,
absolutely. And
yeah,
you know, we've talked about men's health before, and it's our turn to take some heat. But you know, when you're working with guys with heart issues, one of their big concerns, I think Dale, was it you or was it you, Nancy? We're talking about this week when you're working with guys, you know, sometimes they don't want to take their blood pressure med, they don't want to take their cholesterol med because they're worried about impotence and they're worried about their performance, right? So we just have to remember that, you know, we're not these cookie, you talk about this all the time, Dale, we're not cookie cutters, we're not like little segmented, you know, constellations of systems, right? We're integrated. So if I have issues going on with my heart, it's not just affecting my heart, it's going to affect my other organs, including the fun ones, right? So yeah, so that's the fun part about data for nurses is a means to find the folks who need us and a means to really determine how are we going to target our interventions, how are we going to help have these members have a light bulb moment so we can help turn things around. And I don't know, Dale, you've had so many, as we're getting ready to end out a quarter, we report every quarter on, you know, what are we doing for for our members, for our clients, and we report back. These are the wins. Can you, off the top of your head, no pressure, 'cause we didn't prep on it, but you know, you've had so many folks in the last quarter who've really just done amazing things. But tell us some of the things that you've been working on, just for a quick minute, some of the things
Yeah,
that you've been working on with your members and what you're seeing as a result of the work that's being done.
And I have to say that they do the hard work, and I help support and partner and facilitate. So they're the ones doing the hard work. But I mean, I've got one guy, and he is working so hard. He's brought his A1C. It was in the 10s. It's in the 8s now. We're still working on getting it lower, but for him, you know, that's a big deal because it's been uncontrolled for so long, and he's finally, you know, getting control with his diet, with portion sizes, moving more. So that, you know, there's that. We have another member who's he has big goals to lose weight. He's got a new grandbaby. You know, there's just all these things, all these stories. You know, I think it's really helping people find the why, what they're doing and why they want to do it.
Yeah.
And when they do, you know, that's a huge motivation. So so then we get to come along as nurses and partner with them and educate and support. And so yeah, we've got a lot of really good things going on with members. I'm not prepared, but I just know there's some good stories out there.
I think you've had a couple members, 1 or 2 members you've had that have quit smoking and have continued to quit smoking. Smoking is a huge hit to the kidneys because it tears up the inside of the blood vessels. And I just think that's huge. And there are cost savings with those kinds of things. Nancy, you had a member we just worked up today. What was their cost savings for? What did you improve? We improved their A1C again by, I can't remember, 20%, something like that.
It was like 24%. So the savings are over $60,000 for that. You know, for that.
That's awesome.
Member.
That's awesome.
That's a lot. That's major.
Yeah. Or when you help somebody take type 2 diet, and it's always crazy to me when we talk to folks and nobody's told them for type 2 diabetes, you can put that in remission. And it's kind of sad to me that more people don't have that expectation. They just kind of expect that they're always going to have diabetes. So eat, drink, and be merry. I'll pop a pill. I'll take a shot. But most people don't want to do that. They would love to get rid of diabetes, right?
Yeah.
Oh, go ahead.
I was going to say, going back to that, I actually read an article, I think it's today or yesterday, and it's like, okay, you got diagnosed with diabetes, type 2 diabetes. Great. You can do something about that. You know, it's like, not great, but yeah, okay. You can do something with that. So.
Yeah. I was talking to a member earlier this week, and he does not have a diagnosis yet. I say yet. His doctor wants him to come back in and retest, and he's really bummed. And we had him check his sugars, and he's hitting over 200 during the day. Now he has diabetes, right? Now I'm not a doctor. I can't diagnose him, but he's motivated. Why? Because, you know, and I think it's interesting that most of these people that put it in remission, it doesn't take a long time. It's 2 or 3 months. Del, you had a member who recently got off of all of her medications for diabetes, and she's holding it. Right. So, you know, once a member, I think it's a great thing too. Once a member achieves a goal like that, it's not like, oh, good, you're on your own, go away.
Right.
You continue to be available to that member to help her hold on to that. You know, to hold on, let's hold that, make sure that, you know, you're not going to fall back off in a month. Halloween's coming. and
then Thanksgiving, and then Christmas.
Right. And it's tricky. And how do we navigate some of these things? So making sure they can hit a target and hold on to that. Because our goal, really, we want these members to not just benefit right now. We want to make sure 5-10 years from now, after they don't have access to us anymore, they don't need us. That risk has been mitigated. Now they know how to empower themselves. And most of our members are with us for about 12 months, somewhere between 12 and 18 months. They're going to achieve some goals. We're going to close them out. So it's not this continuing drain on your group's budget. At those cost savings, and, you know, just from helping people get off of medications. And right now, the GLP-1s, the SGLT2s, those are getting a lot of press right now. And there's some mixed stuff out there. Maybe we should take a minute and talk about those. They're kind of the darlings and the dangs in the industry, if you will, because they're so expensive. And there's a lot of people out there who, you know, think, gosh, you know, it's just a ploy to get people, and now everybody wants them for weight loss and they're expensive and we shouldn't cover those meds. And that really concerns me.
Yeah.
Can one of you guys do one of you guys feel comfortable talking about why these meds are considered a guideline, a KPI, if you will, for our folks who are at risk for kidney disease? You feel like you can talk about that? No pressure. Put you on the spot.
I'll say this. One, they are renal protective, so they help protect the kidneys.
Yeah.
But there's also, and of course, there's a lot of things that are coming with them too. Yes, you're losing weight, which is giving people more energy to do more, to move more. You're preventing other diseases by that.
Absolutely.
And getting their blood sugar into control. It's helping. They're seeing studies that like it actually helps with cravings, and I see that anecdotally as well with members. It's like, well, I don't feel like I have to go get that bag of M&Ms anymore, and I don't have to do that. So it helps people in that way too. But yeah, as far as, it's part of a guideline just because it does so much, but it's renal protective.
Yeah, the fancy word is pleiotropic. Pleiotropic, yes. Meaning it protects the inside lining of the blood vessels. That's how that acts. Yeah. So tremendous cardiorenal protective effects. So yeah, we're protecting these folks from develop. You want to pay for that drug? You want to pay for dialysis? Hands down, I'd rather pay for the drug.
Yeah.
You want to pay for the drug? Do you want to pay for a heart attack? Yeah, I'd rather pay for the drug. The key is, I think, is that, and one of the reasons why I think our approach is so important is that when you marry a drug without the self-care, the expert coaching, the therapeutic professional, trusted helping relationship, you're going to be on that drug forever. Right. And so I really like how, and I've seen that, we work with these, just like, I know, Nancy, you're working with a member today on diet and changing behaviors so that, while we're getting this incredible cardiorenal protective effects and we're having these wins, appetites are going down largely because of how it acts in the gut. Now they're getting some bad press, right? The same people who are going to benefit from this medication are also at the highest risk for gastric effects, right? Where people, sometimes people have such high blood sugars that it damages the nerve that innervates the stomach, right? And people develop gastroparesis, right? So people with diabetes, I almost lost my noun. Got to dye my hair. It's all gone to the grays, right? Where they develop gastroparesis. And, so it's interesting. I think that, some of the stuff I've read, they're throwing out a lot of bad press about these meds because of the gastroparesis, but these people are already at risk for gastroparesis, and it's going to happen without the med if we don't help them get it under control as well.
Yeah. It's definitely a risk versus benefit situation.
Yeah, and
like you said, like
side of them, helping them with the self-care to really help target that from a diet and an exercise perspective as well, I think is really important. And giving the pancreas time to come back online. Now, type 2 diabetes can also become type 1 diabetes, right? If we kill those cells in the pancreas because of uncontrolled diabetes, we've seen folks, their sugars will go from 50 to 500 in a day. And, they end up with type 1 diabetes. Well, that's a whole different ballgame. We want to catch them before that and help them put that in remission. And, to your point, Nancy, we do that all day long. It's it is the biggest contributor for kidney disease. And quite honestly, every other high cost comorbid out there. So it's important. How do you guys feel about turning the tables and talking about women's health?
Let's do it.
Let's do it. All the good stuff. So our focus in September is on, and one of the things we talk with our members about is making sure that they're getting their cervical cancer screenings is really important. So the guidelines say from ages 25 to 65, we want a cervical screening every 5 years. Not a fun one. Guys, you got your prostate exams. Nobody likes those. They're important, right? I don't know. I think ours is worse. We got to get up in the stirrups and that little salad tongs. They're cold. It's not pleasant.
No.
I've got a girlfriend who heads the nurse practitioner program. And so I've been the guinea pig for a whole round of these things. And yeah, now I'm still in therapy. Not fun, but it's so important.
Oh,
Oh, that's
Mhm.
probably TM.
very important, yes. Nah. Well, and to that point, it's actually important. I think there is somewhat, and with the men too. We talk about other aspects of our health. We should be able to talk about this too. So it's important.
It is important. Sexual
Mhm.
health is really important. One of the other things that we're seeing, I think, is really encouraging. We know the human papilloma virus. When my kids were little, we didn't have that vaccine yet. But we've shown that the vaccine has made a huge dip in the numbers that we're seeing of cervical cancers. I think that's incredibly encouraging. So now we're seeing where the cervical cancers, these kind of cancers, are becoming preventable. Kind of like what we've seen with colorectal or prostate cancers. These are largely preventable cancers. I think that's super exciting. One of the other factors, when we talked about earlier, and we are seeing this unfortunately, but when girls are younger, when they start engaging in sexual activity, they're also at a higher risk for cervical cancers. And guidelines say, engaging in sexual activity before age 16 puts a female at a statistically much higher risk of cervical cancers. So I think that's important too. What do you guys think? And what are your favorite things to talk about when you're talking with folks and counseling them with these kinds of things?
I always think being proactive is key. And we just kind of covered that. I think there are some things that we're used, most people, it's like you go to the doctor when you're sick, you go, you do these things as it happens, and really screenings for cervical or any kind of cancer or any kind of, whatever, you have to make it a priority as well, not just waiting till something happens. So, staying
It's a lot
consistent
easier
with
to prevent than it is to react.
Yeah. Yeah.
Right. Right. I agree. I mean, we shouldn't wait until something's wrong to go to the doctor. We should be preventing, what could happen and what could go wrong. And there's a lot of things that we know could go wrong. So we should be proactively, checking on those things.
Absolutely. And one of the things the guidelines talk about, and I know one thing I get asked a lot as well, I've had a hysterectomy. Do I need to do that anymore? I think I'm done, right?
No.
Well, here's what the guidelines say. The guidelines, and I'm going to read for you. Cervical cancer testing or screening, it should begin at age 25. And it's interesting because you've got different bodies and they all fall, they all have little differences here and there. But in general, these are the guidelines. From 25 to 65, we recommend the human papillomavirus test, the pap smear, every 5 years, regardless of if you've stopped having children. If you're not having children, some people say, well, I don't have children, so it doesn't apply to me. Yes, it does. Regardless of if you've had the HPV vaccine or not. Now, if the HPV testing is not available, then you can do that in combination like the pap test. If you do the HPV screening with the pap test, that's recommended every 5 years. Or if you're just doing, my day, we only had the pap. And I don't know, in my day, we were screening for that every year. And now the recommendations are every 3 years. A primary HPV test is a HPV test that is done by itself for a screening. And the most important thing, this kind of common sense, I suppose, but the most important thing, wouldn't you agree, is to just get screened regularly, no matter which test you get. Yeah. If you're seeing your provider on a regular basis, that's a real thing, right? We look for what's the change in your baseline. It's really important.
Yeah. And I think honesty is important. I think it is hard to talk about delicate subjects with their doctors sometimes. But I think those conversations are important so you can know your risks and you can, get more educated and be screened for, things that could be, out there. So I think it's important to also just go in and be honest and have those conversations.
Open, frank discussions with a trusted provider. So here's a question. Do you guys like to see a guy or a female provider?
Female here.
Female. I
Yeah.
actually had 2 male OBs for both my kids.
Yeah.
But have since switched to female, and I think from here forward I would only see a female.
My best delivery was with a midwife. That being
Mm.
said, my favorite OB I ever worked with, and he delivered my 2 of my babies. He was a fantastic doc. I adored him. I had a doc in the Coast Guard. When I do my pap smear, his hands would shake. I never did trust him. So
Ugh.
that's kind of creepy. It's just kind of creepy.
No.
Yeah, I'm just saying.
Yeah.
TMI.
Yeah.
Well, so here's some more on the guidelines. If you're over 65 and you've had regular screenings for the past 10 years, then they say, and especially if those last screenings have been normal and you've had no history, okay, in the last 25 years or whatever, then they say that then you can stop cervical cancer screenings. And once you stop, that they're recommending it not be started again. If you've had a hysterectomy, that was one of the questions I get asked sometimes. The recommendations are to stop screening, like with a PAP test, an HPV test, unless the hysterectomy was done obviously for cervical cancer or serious precancer. That's really important. And then, you know, that's where you really want to have, like to your point earlier, is talking with a trusted provider. What do you think, doc? What for my particular situation? You know, because we've talked about before, we're not cookie cutters, right? And if you're seeing your provider, you know, on a regular basis, you're going to be able to have, you know my situation, you know, my family history, what would make sense for me. And, you know, if you have some kind of a history of a serious cancer or precancer, you should still have that testing at least 25 years after that condition was first found or diagnosed. Even if that means, you know, you're past 65, then you still want to continue with that, right? So we're not cookie cutters. There are some things that are going to be taken into consideration. If you're a high risk for having cervical cancer because maybe you've had a transplant, right? So people that have had some kind of an organ transplant, we know they're a higher risk for different types of cancer. That's why we tell them to wear sunscreen all the time. And you know, they're higher risk because they have a compromised immune system. It's suppressed is the best word. So really our recommendation are, you know, we'll go over the guidelines, but make sure you discuss your individual circumstances with your provider. Yeah.
Yep.
And, you know, I think it's interesting, and Dale, you talk about this a lot too, but I think there are a lot of things that we do to take care of ourselves generally, right? It's not rocket science. Same things our mamas told us: go outside and play, eat your fruits and vegetables, go to bed early, right? All these kinds of things are what makes up for a healthy, vibrant, joyous body. And that kind of body that's supported in such a way, in a holistic manner, Dale being our holistic nurse, that's really what lends to helping to protect ourselves from a host of things. Wouldn't you agree?
Absolutely.
Yeah.
Yeah.
Well, I got to tell you, as always, I think our discussions are really fun. But coming into September, fall, I always find that there's a couple of seasons when seasons change. I think it's a great time to kind of look inward on how we're doing. You know, personally and professionally, I like to see, okay, where am I? How am I progressing on the goals that I set? But also to prepare my body for a change in seasons to support health. I would love to hear, just as we wrap up, what would be your top tip or top tips to helping people as we head into this fall season?
Nancy, I'm still thinking.
I'm still thinking too. I guess in helping others, you know, we need to help ourselves too in order to help others. You know, we need to be able to take care of ourselves. You know, I know that September for me, I start going on walks, you know, because the South Carolina, the summer is torturous. So, you know, for me, September through, you know, probably March, you know, I go on walks a lot, you know, and now working from home, I make it a point to go on walks because, you know, sitting in front of a computer, you know, I don't get to walk around as much as I used to at the hospital. So, so yeah, so that's one of my things, is that we need to take care of ourselves if we want to take care of somebody else. You know, it's like getting that oxygen mask in the plane. If we don't have it, then we can't help others. We put it on ourselves first, and then we help others.
Yep.
Yeah.
That's the unselfishness of being a little bit selfish.
Right.
Yep. It's really not selfish to prioritize yourself. I think, Nancy, you and I were talking to somebody the other day about, 10 minutes. Can you just take 10 minutes for yourself?
Right.
It's super important. I know, Dale, you and I have talked about that too. If you sacrifice your health because you're too busy, where's that going to take you at the end of your life, right?
Yeah.
So,
Yeah.
what about you, Dale? No pressure.
I don't know. I was gonna say, I don't know. Well, and I think I may have said this. I don't know who I said this to, or if it was on our last roundtable. September to me is almost like a New Year's to me, and I love. I feel like fall is kind of like new. It's like it's the setting up for the next year, because the holidays are coming, and it's kind of a chance, for me, I'm in the time of life where I have kids that are still in school and that kind of thing. So it just feels like that changing of the season. So I love what you said, Kimberly, like there is a rhythm to life. There is a rhythm. And so I think it's important as we go into a new season to just take that time, even if it's 10 minutes a day or 5 minutes. We always tell people, be curious. I think it's just it's self-reflection. I think it's important to self-reflect what's working, what's not working. What do I want? What are my goals? Just allowing ourselves to be a little selfish in that way, with not only for us, but for the people that we love around us. So.
Yeah. Yep. What's the expression? You got to have a gallon to give somebody a cup. I have to have some kind of reserves. I have to have an abundance if I'm going to be able to give. Otherwise, you can't fill anybody's pockets if yours are empty. So,
right.
Yeah. Well, again, I appreciate you guys so much. Our members are so lucky to have you helping them on their journey. I think it's really great that we have this. To me, I've always thought it was a gift. When people allow us into those spaces. I know Nancy and I talked about that yesterday. We had a member in a dark spot, and it's really great to be able to take a pause and go to where somebody else is. I think it's interesting when we talk about helping people change behaviors, which is really what we do here. Why this program is so different, and the reason why we deliver on ROI is because we can engage with these members, and we help these members participate in such a unique way. The nurse coaching model is so different. There's education. There's education, a big part of what we do, but we're not shooting all over people, right? And it's not as directive as it is, to Dale's point. We're building curiosity. What would this look like for you if we did this? I wonder what could be better about your life if we focused on, one thing. And I think when we go to where people are, right, and we sit with them in this space, we can help them, and we can take them anywhere they want to go. But if we're up here and we're shooting all over them and telling them what they should and shouldn't do, and we're spouting out guidelines, and you need to go home and lose weight, you need to blah, 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 you can't do anything. It's really hard to pull somebody somewhere. So thank you for all the work that you do to really help empower. It's beyond motivating. It's truly ennobling and empowering to help people step up into a life that they can really find joy and happiness in. And it's great that we save people money at the same time. Woohoo. All right. Well, thanks again. Have a wonderful rest of the month. Bye, everybody.
Thank you. Bye.
Bye.